So my screen is visible also?
Yeah, visible now. You can go ahead.
Okay, thank you, sir. Thank you. So thank you, Chairperson, for the kind introductions, and also I think we'll discuss it like a simple session regarding the ECG diagnosis and management most likely, and management part maybe a bit of EP may come in the management. So narrow QRS tachycardia, I will go to the next slide. So this is actually the classical ECG of a narrow QRS tachycardia. And in this ECG, we can see that the QRS duration is less than 120 milliseconds. It occurs in a regular narrow QRS tachycardia and a irregular narrow QRS tachycardia. So I will be first discussing a regular narrow QRS tachycardia. So its rate may be around 150, 160, 200 or something. So this is a classical ECG of a narrow QRS tachycardia. My idea is to give you an overview of what are the things you should think when you get such an ECG and how you should react to it. So coming to the next slide. So mostly and almost all are due to the supraventricular tachycardia. Rarely there are some forms of VT which can present as a narrow QRS tachycardia, like a fascicular VT, which can be narrowish, not a typical narrow QRS. It can be have a QRS of width of around 120 milliseconds like that. So you may mistake those as a narrow QRS tachycardia, but those are VT. Then we can see the other things of VT to get into the diagnosis. Okay. So the types of narrow QRS tachycardia, first we have to discuss from where they are coming. Supraventricular tachycardia, it can be an atrial, it can be junctional or accessory pathway mediated. Atrial can be a focal atrial tachycardia, sinus or real-time tachycardia, flutter and fibrillation. Junctional can be either a junctional ectopic tachycardia or an AVNRT. An accessory pathway mediated tachycardia can be an AVRT. Now, whenever in an AVRT we find a narrow QRS, it's due to what is called as an orthodromic AVRT, where the antegrade limb is going through the AV node and the retrograde limb is going through the path, that RNT. The tachycardia can be regular or irregular. The regular tachycardia is usually a focal atrial tachycardia, atrial flutter with a fixed block, AVNRT, AVRT, and JT. Irregular tachycardia can be again atrial tachycardia, atrial flutter with variable block, and atrial fibrillation. So coming to the next slide. So the ECG algorithm I have already discussed, keeping my discussion focused in the narrow QRS part. So what you should see in a regular and narrow QRS. If it is irregular, then I have discussed already what are the things you should look at. Think of. If it is regular and narrow, then you have to look at the RP interval. Means the distance between the R and P. Whether it is a long RP tachycardia or short RP tachycardia. So where the P wave falls on the RR interval, does it fall before the midway of the RR interval? Then it comes to be a shorter RP, and when it falls after the midway of the RR interval, it's a long RP. Now we have to look at the P wave in the inferior list. If you find positive P wave in the inferior list, it is most likely an atrial tachycardia, because AVNRT, AVRT will have a negative P wave in the inferior list. And also you have to look at onset and termination. Usually AVNRT, AVRT will have an abrupt onset and abrupt termination. While if it is an atrial tachycardia or SNRT or something, those will have a gradual onset and termination. Now response to adenosine, whenever you give an adenosine, if a tachycardia terminates, it is most likely due to AV node dependent tachycardia. So AVNRT, AVRT is most likely. AT also can be there where the atrial tachycardia is sensitive to adenosine. And also if you have underlying heart disease, for example, LV dysfunction, rheumatic heart disease, or in ICM, there atrial tachycardia becomes more likely. Okay. Now this is an example of a narrow QRS tachycardia, and you can see the P wave. If you can see the P waves, you have to look at the P waves. So the P wave. So here the suspicion that P waves may be falling on the SP segment, and you can find out the polarity of P waves and accordingly make a decision. So this is one example. So what I have already discussed is the RP and PR interval. If it is a short RP tachycardia, where the P wave is falling before the midway of the RR interval. For example, if I draw here, you can see that it is the RR interval. It is falling before the midway of RR interval. There, it is called as a short RP tachycardia. So, what was the differential diagnosis of my slide visible or not? Hello?
Yeah, it is
Hello?
visible. Go ahead. Yeah, visible.
Visible, okay. So, if the RP is less than PR, it is called as a short RP tachycardia. The differential diagnosis is AVNRT. AVNRT, you may not see a P wave because the RP interval is so short that the P wave will be inside the QRS complex. So you can suspect it. You can suspect it by something called as a pseudo S and pseudo R. So if in V1 there is no R prime in the sinus ECG and you can see R prime in the tachycardia ECG, then you can suspect it is an AVNRT and this R prime is nothing but a retrograde P wave. If it is pseudo S, means if there is imperial lift, there is no S wave in sinus rhythm. But during the tachycardia, you can see that there is an S wave which is coming and there is no P anywhere to be seen. So you can suspect that this S wave is likely to a retrograde P wave and you can suspect an AVNRT. In AVNRT, you will see a clear P wave falling on the ST segment. And atrial tachycardia, definitely, it can be also there. If there is a long RP tachycardia, the most common diagnosis becomes an atrial tachycardia. And then the atypical AVNRT, and then something called as a PJRT, where there is a slow conducting pathway, which is conducting in the retrograde direction. Usually, this PJRT is seen in the children, and they may present most commonly as heart dysfunction, LV dysfunction, rather than tachycardia symptoms. So this is what is called as a focal atrial tachycardia. You can see that there is tachycardia going on and there is multiple P wave and less number of QRS complexes. So this 1:1 ratio is not there. If there is a 1:1 ratio, then AVNRT, AVRT, these are becoming more likely. But if there is more P and less of R wave, then focal atrial tachycardia, atrial flutter becomes more likely. Now, in a focal atrial tachycardia, you can see the P wave and decide whether the tachycardia is coming from which part of the heart. Means usually there is an algorithm by which you can find that. Usually the focal atrial tachycardia has a warm up and cool down. That is called as an automatic atrial tachycardia, maybe adenosine sensitive. And if you have a tachycardia which stops with A before coming to the sinus rhythm, then it is unlikely the atrial tachycardia because that A should have been conducted down. Why it will stop with a A? So another thing you can suggest it in a halter. If you see there is a sudden change in the P wave morphology in the halter, then also it is actually suspicious of an atrial tachycardia. Also, a fixed high rate. Whenever you see a patient and you do an ECG, always it is 130 rate. And it looks like, not typical sinus, but near sinus routine. So that fixedness of the heart rate is unlikely to be a sinus tachycardia. It is likely to be an atrial tachycardia. And whenever you find an atrial tachycardia, always rule out that is it not a sinus tachycardia or not by ruling out anemia and hyperthyroidism. So this is one of the algorithms. I am not going into detail. By this algorithm, it will predict from which part of the atrium it is coming. Usually, the atrial tachycardia comes from the right atrium around the crista terminalis. Then it can come from the pulmonary vein, and then it can come from the CSO. These are the commonest parts. Okay. Now, regarding management of atrial tachycardia, first line management is beta blockers because they are automatic, mostly sympathetic driven. Then, if you have a prolonged atrial tachycardia, that can cause an LV dysfunction, which is called as a tachycardiomyopathy. And whenever you have an LV dysfunction with an atrial tachycardia, it should be ablated because that will cure the tachycardia and cause an improvement of LV function. Also, if the patient is not tolerating beta blocker or not responding to beta blocker, then definitely it should be ablated. So, coming to one of the examples of atrial tachycardia, this is one of the tachycardia where the atrial tachycardia was coming from the right superior pulmonary vein. And by EP study, we can see the signals. And by the signal, we can find out from where they are coming and we go there and ablate it. This is another case where it was an atrial tachycardia, which is coming from the crista terminalis superiorly. So we had ablated this atrial tachycardia, and the patient who had an ejection fraction of 35% had an improvement of ejection fraction to 55% within 5 to 6 months. So all these things are very gratifying when we apply this atrial tachycardia and LV dysfunction improves and there is a mortality benefit by this. So coming to another atrial arrhythmia is atrial flutter. Atrial flutter we all know is a sawtooth pattern in inferior limb, and if you have a typical sawtooth pattern like this ECG, it is most likely to be a typical flutter. Means it is a flutter which is more likely to get ablated by ablating a particular small area of the heart, and the success of the ablation is more. So sawtooth pattern looks like it's a typical flutter, and whenever you find a supraventricular tachycardia and you find the heart rate is always 150, whenever you have a 150 heart rate, please think it can be an atrial flutter with a 2:1 conduction. And you can prove this by giving a simple carotid massage or an adenosine to the patient to bring out the flutter waves and clinch the diagnosis. If you have a structural heart disease, maybe a repaired ASD, rheumatic heart disease, and congenital heart disease, HCM, in those circumstances, atypical flutter is often common, and you have to be ready for that. So this is an example of flutter. What is the management? Acute management is rhythm control by DC cardioversion, and if it is hemodynamically significant, and if it is clinically stable, then another option is to go for chemical cardioversion by ibutylite or rapid atrial pacing or amiodarone. And also always anticoagulation has to be ascertained, and also later on anticoagulation depends on the TAT score. So ongoing management, one thing very important, flutter is a difficult rhythm to prevent by medication, as it is an organized rhythm, unlike an atrial fibrillation. So catheter ablation should be taken as a first choice because it is curative and it is the first choice in typical flutter. But if you have a structural heart disease, you may try amiodarone and other drugs because they actually have multiple circuits and difficult to ablate. So this is an example of radiofrequency ablation for a flutter, which we have done, and a particular part of the rate atrium called the cavo-tricuspid disc was ablated, causing the termination of the arrhythmia. Now coming to AVNRT. AVNRT is the most common SVT after atrial fibrillation. It is seen mostly in adults, but can be seen in children. The more a patient is aged, the more is likely to be an AVNRT. The P wave I have already told, it is not usually visible, and usually it is the circuit formed within the AV node by a slow pathway and a fast pathway. Less commonly, it can be a slow AVNRT. Okay. And also you can suspect AVNRT from the ECG whenever the tachycardia begins by a sudden increase of PR interval at the beginning of tachycardia. It indicates the tachycardia jumping from the slow to above to the slow pathway, and more likely it is an AVNRT. It is sensitive to adenosine. So slow fast AVNRT, what I have already discussed, pseudo S and pseudo R, I am not going into detail of that. And for AVNRT, if you acutely terminate, you can terminate by vagal maneuver or IV adenosine. And if mostly it is effective in 92% of the cases. If it is not vagal maneuvers, you can give in a sitting position, then that is more effective than the vagal maneuver giving in a lying down position. And if it is not converting, there are other drugs you can give, but mostly it will be converted by this. On long-term management, if a patient is an ablation candidate and patient prefers an ablation, then you can go for directly ablation in an AVNRT. And if the patient is not willing for ablation, then you can give drug therapy like a beta blocker or a calcium channel blocker. Okay. So this is another one of the examples of ablation of AVNRT. I am not going into details. We put catheters on the heart, localize the slow pathway by signal and also by position. And we give bonds there. Usually it is effective in more than 95% cases. There is a small chance of AV block, but that is very rare, maybe 0.5% only. Now coming to AVRT, which is accessory pathway mediated tachycardia. So I am discussing mostly the narrow QRS part of it. Narrow QRS is called as an orthodromic tachycardia. When orthodromic means, if you see the figure, you can see that the antegrade limb of the tachycardia circuit comes down to the hip Purkinje system. So it is synchronized and narrow QRS. So that is the most common form of AVRT, and it is called as orthodromic AVRT. The other things like antidromic AVRT, pre-excited AVRT, these are all wide QRS, and I will not be discussing here. So most common variety is narrow QRS, usually most common in children and prevalence reduces with age. And bypass tract which is present can be predicted from the pre-excited ECG. Now, so ECG manifestation, if you have a baseline pre-excitation indicated by a short PR interval and delta wave, it is more likely that the narrow QRS tachycardia, what you are seeing is an orthodromic AVRT, with a retrograde limb being the accessory pathway and antegrade limb being the AV node. This is also like a presence with a P wave, which is in the middle of the AC segment, not like an AVNRT. So it usually is a short RP, but not so short RP as an AVNRT. The principles of management, if it's an asymptomatic pre-excitation, you can re-stratify by TMT, Holter, or AP study. If it's a symptomatic pre-excitation, if symptomatic AVRT, then you have to manage like a narrow QRS tachycardia as AVNRT. For example, here the ablation, catheter ablation is the first choice again, because you have to this AVRT sometimes can cause atrial fibrillation and it can conduct very fast if you have a pre-excitation, and this rarely can cause a sudden cardiac death also. So if you have a pre-excitation at the ECG at some point of time, and you have a narrow QRS or a wide QRS tachycardia and think it is an AVRT, then you should go for ablation definitely. So if drug therapy is given in a patient with pre-excitation, then always it should be a beta blocker and flecainide. Now, these are the things which I am not going into detail. So definitely it is an ablation candidate and willing to undergo ablation, you have to undergo ablation. If not, then you have to give a beta blocker plus flecainide or proportional. This is a patient where we had ablated the pre-excitation in the pathway, and I'm not going into details. Now coming to the most common SVT, which is the atrial fibrillation. Atrial fibrillation is identified by the irregular RR interval, no definite P waves, or you have an irregular P wave, often associated with structural heart disease, and the prevalence of atrial fibrillation increases with age. So as a structural heart disease. Structural heart disease can be RHD, HCM, CAD, or an LV dysfunction. Acute AF can occur in pulmonary infection, thyrotoxicosis, critical care patients, and post-CABG. And atrial fibrillation, if it lasts for less than 7 days or doesn't need a cardioversion, then it is called as a paroxysmal. If it needs cardioversion and more than 7 days, it is called as persistent. Many of the persistent atrial fibrillation nowadays is being ablated, even if it is more than 1 year. The intent to ablation makes them as a long persistent atrial fibrillation. Permanent atrial fibrillation is only when the doctor and the patient decide that they will not go for rhythm control.
I'm extremely sorry for the interruption, sir. There are 2 minutes left for the presentation. Thank you, sir.
It's almost ending, no problem. So treatment of atrial fibrillation, one most important thing is to prevent even stroke. So that should be anticoagulation based on the CAT-VAS score. Symptomatic treatment can be with rate-reducing drugs, or rhythm control is better to control symptoms, especially for paroxysmal AF and without any structural heart disease. So these are the things. I am not going into detail of that. Based on structural heart disease, if there is no structural heart disease, you can continue rhythm control by drugs like flecainide, propofenone, etc. If there is structural heart disease, then amiodarone and dofetilide are important. So indication of catheter ablation, paroxysmal AF, you can go for catheter ablation if the patient is willing, or the patient is not willing to take antiarrhythmic drug. If you fail one antiarrhythmic drug, then you go and go for catheter ablation. In persistent AF, then also it is a catheter ablation as a second line when you fail antiarrhythmic drugs and the patient wants a cure of the rhythm. So this is how we go for catheter ablation. We isolate the pulmonary vein because most of the atrial fibrillation begins as a triggered activity which begins within the pulmonary vein. So this pulmonary vein isolation gives rise to around 75% chance of cure of atrial fibrillation, cure of atrial fibrillation in the first therapy. Thank you.